afternoon and good evening to all our speakers, shares, and the wonderful audiences in different parts of the world. Welcome back to yet another episode of very educative lectures for you at the ACNS webinars. The speaker for the first session of today is our honored guest from Australia, Dr. Sarah Olson. Dr. Olson is a neurosurgeon in Brisbane, Australia, and immediate past president of the Neurosurgery Society of Australasia. She was the past supervisor of the neurosurgical training at the Princess Alexandra Hospital for 10 years. She is a surgical education and training board member of Australasia and member of several subcommittees. She is a functional and oncological surgeon and a member of the Gamma Knife clinical delivery team. Her interests are functional neurosurgery, trigeminal neuralgia, awake craniotomy, pituitary disorders, and gamma knife treatment for neurosurgical conditions. We are extremely honored to have her today at our webinars, and today she'll be talking about targeting in DBS. The speaker for the second session of today's webinar is our honored guest from the USA, Professor Leah Al-Hilali. She is the Director of Neuroradiology at the Ivy Brain Tumor Center and Professor at the Barrett Neurological Institute, Phoenix, Arizona. She is an excellent educator and dedicates her life to both offline as well as online teaching through her regular educative posts on various neurosurgical and neurological diseases through wonderful illustrations and mnemonics. She won the Teacher of the Year award at the Barrett Neurological Institute consecutively for 5 years in a row now. She has authored and co-authored several manuscripts and is in various acclaimed journals. We are extremely honored to have today at our webinars, and today she'll be talking about brachial plexus, anatomy, imaging, and pathology. The chair for the first session of today's webinar is our honored guest from Japan, Professor Shiro Horisawa. Professor Horisawa is a consultant neurosurgeon at Department of Neurosurgery, Tokyo Women's Medical University, Tokyo, Japan. His research interests are focused upon lesioning surgeries like radiofrequency, gamma knife, and focus ultrasound. He also specializes in DBS, spinal cord stimulation, and intrathecal baclofen. He is an important member of the Japanese Neurosurgical Society and also a member of the Board of Directors, World Society of Stereotactic and Functional Neurosurgery. He is a noted author with several publications in various period journals, and we are extremely grateful to him for accepting our invitation to chair the first session of today's webinar. The chair for the second session of today's webinar is our honorable guest from India, Professor Keshav Das. Professor Keshav Das is a consultant neuroradiologist at the Department of Neuroradiology at the Sri Chitra Institute of Medical Science and Technology, Trivandrum, Kerala, India. He is one of the most acclaimed neuroradiologists in the country. He did his fellowship from the Scientific Institute and University Hospital San Raffaele, Milan, Italy. He is also a recipient of several awards and honors for his outstanding contribution to neuroradiology. He is a noted author with several publications in various peer journals. We are extremely grateful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kaito, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this on the WeChat channel. Dr. Liu Bun Singh from Malaysia is my co-host for today. And with that introduction, I would like to hand over this online podium to our first chair, Professor Shiro Horisawa.
Thank you, Raja. I always really appreciate your great contribution to the society. And today we have a great, wonderful presenter, Professor Sarah Olson from Australia. She will talk about targeting and DBS. Please start your presentation, Professor Olson.
Thank you very much for inviting me tonight. I'm delighted to be here. So I'm talking a little about deep brain stimulation for movement disorders and new horizons. So the main indications, and will remain the main indications at this point, are for Parkinson's disease, tremor, and dystonia. But we'll talk a little bit about these other disease states as well. We'll also talk a little bit about thermocoagulation lesioning. DBS was quite late coming to Australia. So I learned thermocoagulation lesioning for quite some time until the first case we had approved was in my hospital in Australia in 2006. And then we'll talk about DBS. I also work in gamma knife. We have a focused ultrasound starting very shortly at another hospital that I'm hoping also to be involved in. I'm not a transcranial magnetic stimulation. We're just discussing. I have no experience with it. So when the original papers were published back in the 1960s, they were with radiofrequency lesioning. Very impressive, really, just with X-rays. So they really couldn't see the structures at all. So very reliant on being able to locate AC, PC, and the XYZ coordinates relative to the mid-commercial point. My understanding is then they'd line up these ball bearings to get their accurate trajectory. Very impressive, and got really good results. Now, radiofrequency lesion, this is a bit of a bane with me, as I don't think we should ever have let this out of our armamentarium. It has the capacity to help all of the world's population, I think, rather than just the 20% that can afford DBS. So it was fast, it was effective. It would take probably me about 2 hours. Very cost efficient, because these patients would have one lesion and then they'd have one post-operative visit, and there were no ongoing needing for changes in their programming. It was, from the neurology perspective, very much easier than because now the DBS patients are their patients really for life, and they involve a lot of our work. But there was a problem, particularly with bilateral thalamotomies with radiofrequency lesioning. We could do bilateral pallidotomies, but certainly bilateral thalamotomies were thought to be a no-no. That hasn't been the same, though, with gamma knife. Sean has shown you can do bilateral thalamotomies, and with the focused ultrasound, you can as well. The other problem was you really had to be very good at targeting. And I thought that was a good thing. You know, you really had to hit that target. There was no reversibility or flexibility of settings. And once you made that lesion, it was permanent. And the lesion size could be a little bit unpredictable. So this is me almost 20 years ago now. So we see the radiofrequency generator in the back there. So it was a simple probe, went in through a burr hole. We did test stimulation to see we were in a good area. We weren't getting any negative effects. Then we would do a test lesion, a very low temperature lesion, again, to make sure we had good effect and no side effects. And then we would do a permanent lesion. And as I said, it was all over with usually within about 2 hours. There's always been a very big team involved with movement disorders. I'm actually probably the smallest part of the team, I think. The neurologists, movement disorder nurses and educators, specialised allied health, neuropsychology. We want to make sure that they don't have any cognitive issues before surgery, as we can make them worse. And also any psychiatric disorders. Whilst it's not an absolute contraindication, we need to make sure that they're treated prior to surgery, and particularly when going into STN, we want to be aware of any compulsive personalities or substance abuse. Specialised anaesthetic staff as well. How does DBS work? Well, you'd think, the most simple understanding of it is when you stimulate a cell that you're actually paralysing it, and it's not being able to express its neurotransmitters, but it's not that simple. It's probably a combination of all these things. For Parkinson's disease, few treatments are as effective as DBS in controlling the motor symptoms of Parkinson's disease. Symptom improvement can be for usually 5 to 10 years. And it's like the second honeymoon for patients, where they get the first honeymoon with levodopa and then they get the second one with their DBS. But it's not particularly effective in gait and other axial symptoms, and does little to improve or can even exacerbate speech ineffective and cognitive symptoms. I just want to mention Patrick Blomsted's Stereotactic Academy, particularly for our trainees in the audience. Patrick is an amazing educator. He's from Sweden. So you can join this for free, and these are quite short sessions, video sessions. And even though I've been doing movement disorders now for years, I have found them invaluable. And I've reverted to a lot of Patrick's ideas and targeting. VIM, actually I use Jean's plan for targeting VIM. I have about 5 ways of finding VIM, and what's always very disconcerting when 5 of them give you 5 different targets. But this one seems pretty reliable. So you can't see them, even on our best imaging now. And while we're a heck of a lot better than skull x-rays, even on 5-Tesla MRI, it's quite hard to see VIM. So you can, this is probably the only time I might use the maps, but usually I rely on these old default coordinates for VIM, and these are the same ones I use for gamma knife. The trouble with VIM is that you can see this habituation. Now, over time, it just doesn't work as well. and the emergence of long-term adverse effects such as dysarthria and gait ataxia after chronic stimulation. We've taken to turning the batteries off at night, but that's still not all that helpful. I'll talk a little bit about closed loop systems later. They may, in fact, hold some answers for us. Whether direct targeting of fibre tracts would provide better improvement is uncertain. So if you think an essential tremor, the original problem is in the dentate nuclei of the cerebellum, then potentially targeting along the dentorubrothalamic tract, you could have multiple contacts along it. And there are two contacts in two places we know we can find. One is the VIM, and the other one is the posterior subthalamic area. And again, this is Patrick's targeting. So he uses the roundest part of the red nuclei, comes through the middle of it, down the side border of the STN, and then you make your little mark a third of the way in from the STN. So you want to get into that nice blue zone there. And it's a white matter tract as opposed to VIM or STN. So you don't have any stimulation feedback coming to you when you're doing your microelectrode recording. You shouldn't have any. So what I do now is I look at our sweet spot for VIM. This is the one that has been inputted from several surgeons into the software. So that is my blue mark there. I target the posterior subthalamic area, drawing a line between them and take it out to the cortex. That should be along the dentorubrothalamic tract, or you can use the dentorubrothalamic tract directly, as in this case. So this is a boy who unfortunately lost his arm in a motor vehicle accident, and the other one's developed this horrible tremor. So we targeted along VIM to PSA, and I have to say PSA is very, very profound in terms of getting a response. It really happens very quickly on the table, profound response, and a big microlesion effect for several weeks. So this is him a little later. So he's now able to hold down a job, and even more importantly for him, he's no longer socially isolated and able to go out and with his friends for a drink. So PSA is an alternative to VIM, or as I said, you can use both of them very readily and target both of them at the same time. And in terms of energy consumption, PSA uses less and compares very favorably with VIM. To be honest, I find it probably more reliable. And I have yet to see so much the habituation we used to see in the speech issues when chronically stimulating VIM. GPI, we can see on a nice F-data sequence. I do use the default coordinates. I don't use the atlas at all for this. Now, Professor Blomstead also is if you can move the target just up into the lateral corner with the optic radiation, you can get a really nice trajectory down through the GPI. So he suggests you move your target just to the upper lateral corner in the coronal image. And of course, there are two functional zones within the GPI. I use mainly STN for Parkinson's because most people want a medication reduction. That seems to be a priority for them. And the only way I can really do that is an STN. I am thinking when we get a lot of patient with a lot of dyskinesias, particularly the older patients, whether instead of targeting STN and then reducing their medication, whether I'm better off targeting GPI, as I've had two patients now with chronic subdurals with their dyskinesias after surgery. The dyskinesias take a while to go after reducing their medication. So STN, the traditional coordinates are at the bottom, but you can see STN. So I would use a combination of FLAIR and SWE. SWE is reliable in this area, but not at the GPI. So again, I'd use Professor Blomstead's method of coming across the top of the red nucleus, down the side of the STN, and just that little mark there. And I found this invaluable because people's using the patient's own anatomy, I think, is always far more reliable than trying to fall back on default or atlases that have, just been an average of a small number of patients. So you can clearly see the red nucleus, you can clearly see the STN, and I think this is very easily direct targeted off imaging. And of course, this is what the STN sounds like. To me, that sounds like rain on a tin roof or popping corn. And all of us who do this type of surgery, when we're going through the area, are just hoping we hear that. And it's always a little bit anxious until you hear it. And then you feel a lot more relieved that you're in the right area. And even better if you can get your trajectory coming straight through the STN, coming a little bit more laterally, trying to get along the long axis of the STN. And then you've got a number of electrodes within it. So this pivotal study showed that early DBS in patients with early motor complications resulted in better outcomes. So there was a big swing to not waiting until the patient was too old. We used to have a cutoff of 70, but I have a patient coming up who's 82. I must admit I'm a bit anxious for that for DBS. He assures me he comes from a family that lived to in their 90s and 100. And he still walks 12 Ks a day. So, but I have to say, just challenging in the older brains, they always get knocked about quite a bit more. But certainly we're changing a lot. We're doing it earlier, and we are pushing the boundaries more in terms of age. So with DBS, the STN and GPI are the common targets for Parkinson's. I almost always just use STN. STN might have a great effect on motor symptoms and reducing the medication, but it can have some adverse cognitive, particularly visual processing and mood effects. This is a patient from Fiji I had. It was very important to him that his family didn't know that he had Parkinson's disease when he returned to Fiji. And as you can see, he's quite bald, and he certainly didn't want them knowing that he had neurosurgery. So this is when I really started to reduce the size of my incisions to only a few centimeters, and went away from using the caps, particularly in men, because as their hair receded, the caps really looked like horns, and they hated them. And in fact, a couple of them I had to remove and put in the bone cement. So he's doing really well. And now with remote programming, it's not an issue for him being in Fiji. And during COVID, it wasn't an issue. We could still manage him from Brisbane. But chronic DBS has also created a new phenotype of Parkinson's patients in whom bradykinesia, tremor, rigidity, and on-off fluctuations are improved. They continue to have the progressive gait, speech, and cognitive issues. Never fear. Apparently, spinal cord stimulation is. I have no experience with this, but I do know some people I've known in the past, like Clement Imani, is very, very clever fellow. So we'll have to see how that might be helping freezing of gait. Epilepsy is a very promising and I think good target for DBS, and I have done a few cases of this in the anterior nucleus of the thalamus. It is becoming an established therapy. There may also be improved executive function, depression, anxiety, and mood. These are more experimental. They've been around now for quite a long time, like minimally conscious state. There's been, the efficacy is very questionable. Sometimes changes in consciousness have been demonstrated, but you could not ever, I think, ever say this was anything other than experimental. Pain has been a bit disappointing. We've really gone away from this in Australia now. Don't tend to use it for pain. The one I'm most interested in for pain will be focused ultrasound and central lateral nucleus of the thalamus. So that will be for people with post-stroke pain, anesthesia dolorosa. There's ones that potentially need a central treatment. But I don't, it would be very rare now, I think, to do DBS for pain in Australia. Dementia, I think we were all excited when Lozano put out first studies with dementia. But unfortunately, it was failed to demonstrate a positive effect in the treated group. There might have been a positive effect in the above 65-year-olds, but certainly not anywhere near as promising as we had hoped. Tourette's, I've done a few patients with Tourette's. That's promising, but the varying results must still be considered experimental. Certainly the patients who are less severe seem to do the best. Anorexia and obesity. Well, there's anorexia actually, if you liken it, the pathways to OCD, and the targets are the same, there has been some very promising results with anorexia, whereas with obesity, it's been far more challenging. Autism, aggression, PTSD, and schizophrenia, again, all experimental and small numbers of patients. We're only talking 3 or 4 or 5. OCD is the one I would really dearly love to see approved, and in my state, Queensland. A little bit goes on in the other states, but it's very challenging for the patients. There's a lot of hoops they have to jump through, and many of them actually give up because of the process before they can even get to surgery. But I think it's probably the most promising psychiatric indication, with significant reduction in their Y-box. The targets, there's multiple targets in the literature, but they're all very similar position, just they've moved slightly more deeper and slightly more posterior. Metabolic imaging can help us in tractography, as I said before, but the metabolic imaging will also show us the changes that happen in the brain with stimulation, which will be particularly helpful in the psychiatric disorders. Depression, I was in Toronto when the depression trials were undergoing, and I felt there was no doubt that it seemed to be working, at least to me, but it was really, really disappointing in the large randomized control trial that they didn't show a significant improvement between the two groups. So why don't psychiatric disorders have more of a role? Because, psychiatric disorders are much larger cost to society than movement disorders. Numerous targets makes it a bit confusing, and there's no consensus. And really, it's the neurologists that drive the movement disorders. I have yet to be asked to do a psychiatric case. The psychiatrists, also and neurosurgeons, all have a little fear of psychosurgery that I think relates back to Walter Freeman and the fallout from that, which is an interesting story all on its own. But certainly, I hope the future would see at least some OCD patients having more access to treatment, whether that be through DBS or focused ultrasound or gamma knife. I just would like to see some of them coming. They are really terribly disabled. So where have we come? Well, we have much, much better imaging from the X-rays that I showed you in the start. We can see targets, and we can use tractography to help us see their targets. We can use metabolic maps to see the effect we're having in the brain. We can use computer-aided training and programming with machine learning and probabilistic stimulation maps. So the thought is, if we can all contribute our data, we can really find the sweet spot for these patients. Directional leads have really changed things for us. In some ways, well, definitely for the better, but often I think, well, we really had to be absolutely nail it when we're doing radiofrequency leading. Now I think there's a tendency to think, well, the directional leads will get us over the slightly suboptimal placement, which is not such a good thing as a surgeon. I think that real obsessive attention to detail was a good thing. The other thing for the neurologists is it creates a lot more configurations for them, and so their workload is really blown out. Remote programming, as I said, I've got several patients in the Philippines. The Lubag disease is a real problem for them in certain parts there. And it's an X-linked dystonia, life-threatening. So we can program them here from Brisbane. And as I said, during COVID, that was fantastic. The shorter pulse width with new pulse generators is helping us as well. Now, this is where the key is, I think, and I liken this to trying to replace pituitary hormones after pituitary surgery. Because you're giving them a constant hormone, you never quite get them right, and their quality of life is never quite the same as when they had intact hormones themselves and they had their own pulsatility. So the closed loop system is like an adaptive stimulation. And with tremor, it wouldn't be your stimulator would not be on all the time, but only triggered when you're going to do something with, say, essential tremor. And you can see perhaps in epilepsy, that would be fantastic. You wouldn't need the constant stimulation. You'd need something in the microenvironment that was going to tell you you're about to have a seizure, and then this would kick in. So this is in the pipeline. Awake or asleep, there's increasing evidence to suggest intraoperative CT or MRI guided placement in asleep intubated patients can result in identical outcomes. And as a surgeon, of course, much more improved patient comfort, far less complaining, and the blood pressure control is a lot easier with them asleep. Technically, from a surgical perspective, it will be better, I think, for the patient. There would be better operative efficiency and increased safety, I think. But I don't think this is my call. It has to be my neurologist's call. And at this stage, he wants to do it awake. And why is it his call? Well, he's the one who has to follow them up long term. And he likes to be in the operating theatre and know that he was a definite part of where that lead was placed, get the inside knowledge of what was happening in the operating theatre, and then he won't be for the next 20 years saying the damn surgeon put it in the wrong place. So at this stage, I will leave that call to him. So the complication rate has decreased over time. We are pushing the envelope, I think, with these older patients. But nonetheless, it is there. And you've got all the hardware complications you didn't have with lesioning and you don't have with gamma knife or focused ultrasound. So problems can be with DBS, and it was another bane for me, is that people don't treat them like pacemakers. They don't know what to do with them. They don't know to put them into safe surgical mode, and they don't know that you can't use monopolar. You can use a plasma blade, and I use that all the time with patients with DBS. But this is a patient who had long segment thoracolumbar fusion, and nobody did anything about his DBS. And he has had bilateral subthalamic lesioning from the monopolar. So ultrasound is, I think, it will be really helpful. And unlike gamma knife, you can do a test lesion and then a permanent lesion, and it works straight away. Gamma knife takes some time to work. These are only used for or STN. Just tremor. So they start, if they're happy with it, then they do a permanent lesion. The skull density ratio can be a problem, particularly in Asian people. And so up to a quarter of those patients, the skull density ratio is too low. Gamma knife thalamotomies, I do these for patients who are not suitable for surgery. Done unilateral. However, Sean Regis has done bilateral. He tells me it's safe in staged settings. I do use, as another thing, you can see that pre-limbiskal radiation coming off the corticospinal tract as an added to know that I'm in a good place. Transcranial magnetic stimulation, I have not been involved in this, but and you sort of look at it and go, goodness, how could that work? But can actually penetrate 6 centimetres into the brain. It generates a changing electric current in the coil, inducing a magnetic field, and then the field causes a second inductance of inverted electrical charge into the brain. And there is heaps of data emerging for autism, depression, anxiety, OCD, Parkinson's, rehabilitation, and you can see the changes in the FDG PET changes in brain metabolism. Of course, it's really non-invasive. The treatment lasts 30 to 60 minutes, 5 days a week for about 4 to 6 weeks. And in Australia, it's covered by Medicare. Transcranial direct stimulation, a very similar idea. As I said, there's just stuff appearing everywhere in the literature. Now, patients are, of course, read a lot. Now we have, the internet. They want to, and they are starting to opt for more minimally invasive procedures. And for some patients, like I think I would be one of these patients, I would be unwilling to attend multiple appointments all the time with a neurologist. I would see that as a real poor influence on my well-being in life. I would like a one treatment and that would be it. And DBS, of course, is not that. Also, if you're thinking about focused ultrasound, some people are just unsuitable for it. If we need to do gamma knife, I really need a MRI, and because you can't have an MRI, that can be a problem. If you've got a bleeding disorder or high medical risk, then you can't have DBS even if you want it. And cost can be an issue. Here we do have a certain number funded in the public sector, because the actual cost of the DBS is about $33,000. Focused ultrasound, if you want to get that in Sydney, you'll be $24,000 out of pocket. The one coming in my state will be covered by the government. So I think it's likely tractography and visual anatomic targeting will be more common than MER, and more patients will be operated on under general anaesthesia. And we're feeling more increasingly confident about that because we've got much better imaging really to guide us. And also we've got directional leads, which can help us overcome suboptimal placement. Registries where we all contribute, I think, will be important. And closed loop systems are quite fascinating, and I think they will show particular promise in epilepsy and tremor. IPGs that are going to get smaller and more effective. I hope there will be more OCD, particularly treatment, but I can't see DBS for psychiatric disorders other than happening in the same way as it does for movement disorders. Less invasive procedures will have an impact, and I think focused ultrasound will have quite a big impact when it's more readily available. Gamma knife for tremor, as I said, you can't do a test lesion, it doesn't work straight away. But while we haven't had focused ultrasound, I have been doing quite a few gamma knife thalamotomies. Transcranial magnetic stimulation, well, I haven't seen that in action, but certainly there's quite a lot of data around about it. And I do have to say, I think it was a tragedy that we let thermocoagulation effectively die out. It was reliable, and I think really had a huge role to play still. I still do it occasionally for patients, usually ones who are going to need repeated MRIs. And of course, there's that ongoing issue with DBS, although that is slowly being resolved. And I think that it had the potential to be a huge help for the whole world's population. And I just wanted to acknowledge our team. Up on the left is one of my great mentors in Auckland. He did everything off CTs when I first started in the early 2000s, Dr. Bracial. Anna, our movement disorder nurse extraordinaire. The nurses in theatre have been with me the whole journey. We have a dedicated team. The Plexus frame, the nurses love far more than the CRW frame. I can see their relief immediately when the Plexus comes in. It's a lot more straightforward for them. And of course, our patients. So the fellow in the top right arrived from the Philippines. He was about 38 kilos. He was in bed, nasogastric feeding, with this horrible Lubag disease. We'd already operated on his uncle, and that's him a few months later. So as I say, it's just a delight to look after these patients, and I'm just probably the smallest part of this big team. Thank you.
Okay, thank you, Professor Olson. Sorry for my bad connection. Me? Okay, so thank you for your wonderful lecture. Very nicely review of all kinds of the functional neurosurgeons for movement disorders and beyond. And at this moment, we don't have not any comments on the chats. And I have several questions to you. And first of all, for tremor surgery, and there's still debate which is a better target, VIM or PSA. for tremor. And actually, I don't use the PSA for tremor because we always use a radiofrequency region for VIM. And all of the patients are very happy after this procedure. So at this moment, we don't need the PSA. But I'm really interested in the difference of the complications between the VIM and the PSA. So which targets do you prefer in the treatment of essential tremor?
Thank you. That's exactly it. People don't know between VIM and PSA. We would use VIM for years and years, but when we started using PSA, we suddenly became a convert to it because the effect was so profound straight away on the operating table. But just try to get away from that habituation problem, and because there is some people don't know which one is better. My thoughts was with my neurologist, well, let's make sure the lead goes through both of them. And then we can use a combination. And hopefully in time, if there is a problem when you've got the habituation, then you can change your programming a bit to move more towards PSA. But somewhere along that dentorubrothalamic tract, we used to think it was a target we had to go to, but probably not. Probably with all of these, it's probably a tract. And if we can find the right tract and get our trajectory down it, then we have multiple contacts along that tract and multiple options for the future.
Okay, that's good. And another question about the psychiatric indications. And do you think that DBS or as a FUS or as a kind of a neuromodulation for psychiatric disorders will be clinically practical in the future, especially in your country and in Japan? And the DBS or as a tactic surgery for psychiatric disorders remains very difficult because a psychiatrist is still rejecting. They are not reluctant. They are reluctant to.
Yes, I find it fascinating. Exactly as you say, it sounds like in Japan, it's very similar to Australia. There is this real reluctance and this big hangover from Walter Freeman. I was listening to Ree's disorders, particularly OCD, and his is a really targeted approach. But he was also comparing some of what he was doing to Walter Freeman and what he had done in a much cruder way. And the effect was the same. It was the same tracks that were affected. And of course, the legacy, as I said, the legacy of Walter Freeman is really interesting. Probably not everything he did was bad, but certainly moving into the children and the bored housewives of the 1960s probably wasn't a good idea. And now the legacy is still hanging over us. 70 years later, people remember, that these kids have frontal lobotomies just for acting out, or it's a I think the psychosurgery is, whilst it's still in living memory, is probably not going fast.
Okay, thank you so much. So I really appreciate you covered so much wider field of functional neurosurgery treatment. Every younger neurosurgeon should learn from your good slide presentations. Thank you so much for your wonderful presentation.
I think we're all learning, aren't we? We're all still learning. I'm very much hoping to do the focused ultrasound very shortly, like you do. So that'll be a new learning experience.
Thank you so much.
Thank you very much.
So Dr. Raja, we should move on to the next.
There are some queries, of course. My friend Dr. Ben has joined me from Hong Kong. Ben, would you like to ask any questions?
Yes. Hello, Dr. Roger, and hello, Professor. And I'm Ben from Hong Kong, a young neurosurgeon. So thank you for your very comprehensive lectures on targeting for a functional neurosurgery. So I have some questions for you. My first question is about I can saw that you have experience in many different modalities of treatment. So may I ask for Parkinson's disease and for those essential tremor, how would you choose between the DBS or lesioning like RFA? How would you choose which kind of modality you would use during your daily practice? And my second question is about the role of the medical stimulation, also the MER during the DBS. I can see that in your slides, you mentioned that probably the tractography may be more important. So in your daily practice, how would you supplement each modalities to help you have a more precise targeting during the surgery? Thank you, Professor.
Thank you. Well, the first question, people are fit and well and able to tolerate DBS. We would normally offer them DBS first. However, if they're not fit for anesthetic, then they have the options of gamma knife or focused ultrasound. As I said, the focused ultrasound here in Australia comes with a price tag at this stage. So I still get a lot of gamma knife referrals. The downside of gamma knife is that I'm not going to do both sides. I know other people are. I've only done unilateral. Whereas the focused ultrasound, they are doing both sides. They do get a bit of ataxia, some of those patients. The gamma knife doesn't work straight away and it can take some months to kick in. And you can't do a test lesion like you can with the focused ultrasound. And so the biggest thing, though, is patients come and tell you what they want. They've been listening on the TV or they've been reading something, and you have to make an argument for what you think you would have in their situation, and explain all of the options to them and be quite open about it. But I think if the patient is fit and well enough, we would still consider DBS as our first option. Radio frequency lesioning, as I said, it was a beautiful operation. It still is a beautiful operation. But it sort of got a bit of bad press when DBS came in. It was really, I think, driven by companies. And there was never any real evidence that it was DBS was a lot better than radio frequency lesioning, although we all knew that potential problem with bilateral thalamotomies. And that was always quite troubling, that it was really, I felt, mostly company driven. And I still think that we should know about radio frequency lesioning. It would be rare for me to use it these days, but it's still very helpful in your armamentarium. And the next question, well, I'm seeing it as my role to get the best possible imaging and tractography and make sure that I never have to move my leads during the procedure, so that eventually my neurologist will tell me that he's okay with me doing it asleep, because I would sure prefer that than awake. But it's up to him, as I said, because he's got them long term, so I'm not making that call. That it's his he has to look after them for the rest of their life, whereas for me it's just the battery changes and the post-operative visit. So when he is happy that we have got our imaging right and we're not moving the leads during surgery, which we very rarely do, I have to say, very rarely, and especially with the directional targeting, you can overcome a lot of a suboptimal placement. So I think that the time is coming that he will be happy with our tractography and our preoperative planning, but not at this stage. So I've still got a lot of work to persuade him.
Yeah, Professor, may I also ask, would you do your DBS under awake surgery or under GA?
Well, we do it awake because that's what my neurologist wants. What I want is asleep. But as I said, it's up to him. It's his decision. It's not mine.
I see. So because sometimes I'm also come from centers with different expertise concerning whether they want to use a wig or want to use a GA. Some may think that the GA may have a more, you may conduct the surgery in more controlled manner to avoid patient unintentional movement during the surgery. So another things I would like to ask is about the BIS monitoring. Have you encountered using the BIS monitoring during the DBS surgery? Any role of it?
No, well, our patients are awake at this stage, so no, we don't. We don't use BIS monitoring. But I can see plenty of perks to being asleep. As I said, patient comfort is a big thing. There's no complaining, and the blood pressure is nicely controlled, which is can be an issue. The whole unpleasantness of the being awake in the operating theatre and the time it takes. I think, it'll be much more efficient asleep, but that is very much an onus on us, as you were saying, is to get the imaging as good as we possibly can and our targeting as good as we possibly can.
Thank you very much. One question I would like to address to Professor Olson is, what happens when the symptoms recur? Is there a role for doing it again?
Yes, I think so. I've got a man with a bad dystonia, actually, and he's going to end up with 2 different targets shortly. He's got bilateral PSA in at the moment, and we're going to do bilateral GPI and travel them down the other side. I have a man who was I did radio frequency lesion on, who's coming to see me shortly, back in 2006. And so now we're going to put in DBS for him if he's well enough. I think that's definitely an option, and we'll cover the PSA and VIM target for him. So yeah, I think there is still plenty of options. Obviously that habituation problem can be an issue. I've got a lady who's turned up her stimulator so high to get rid of her head tremor that when she does that, she can't speak properly. And I would dearly love her to reconsider going back and doing the PSA and the VIM target, because she has only got VIM in at the moment. And I think we could get her better than we've got her. But, certainly there's always a little bit of reluctance to go back a second time and put the patient through it again. Because your first chance seems to be your best chance. And there isn't that many people this seems to happen to, except, that habituation you see with VIM over time. But I think now I'm targeting both of the targets and get it right along that track. I think so far, although it's probably only been the last 7 years or so, I'm seeing less of that. And not so many people reconsidering their target.
Well, thank you very much. We have our second chair joining us. Before closing, we'll take one last question from my co-host Liu Bun Singh.
Yeah, thanks, Raja. Thanks, Professor, for very nice diagram and very educative talk. 3 quick questions, Professor. A patient who are newly diagnosed with Parkinson's disease, how early should we treat with DBS for the best effect, long-term effect? Secondly, if we follow up those with DBS long enough, would the effect weaning off, meaning how long would it take, whether it's same with L-Dopa or whatever medication? My last question, Professor, does the pulse pattern affect the ability of the DBS in terms of neuromodulation? Thank you, Professor.
Okay, so yes, sorry. So how early? Yes, well, that again is not so much my decision as my neurologist, but certainly we're doing them a lot earlier than we used to. Those early motor fluctuations. So I usually say to a patient, I can get you as good as you are in your on state without the fluctuations. So what bothers you the most? Is it your tremor? Is it your freezing? Now, tremor is a little different because that one I'm not too bothered if it doesn't go away without dopamine, because the target is not so reliant on it. But if I say, okay, so if you're good in your on state and no one would know you have Parkinson's disease, but your medication is escalating and you want to reduce your medication, then now will be a good time to consider surgery, especially if they're cognitively well, because once they're cognitively not well, we know we can make that worse. So yes, we have quite a lot of young patients. I just actually had a 26-year-old girl who was training in surgery and noticed the tremor in her hand. So she has Parkinson's. You'll never guess what was a deal breaker from her. It was not so much I would talk about the operation and the risks of the stroke. It was could I do a minimal hair shave? That was a deal breaker. So that would be my answer to that question. And I think, as we said, it's no cure, but it keeps people functional, I would say at least 5 to 10 years. I'm hoping with the new systems and adaptive systems, more contacts, that will be extended, because we will be able to use more combinations and also have it adapt to the environment. So I'm hoping that we might see that more move to 10 to 20 years in our lifetime. Yeah. So I think, as I said, it's the second honeymoon for patients. The first one with dopamine, the next one with the DBS. And the last question I didn't quite catch. What was that? Was it about pulse width, was it?
The pulse pattern. Does the pulse pattern affect the ability of the neuromodulation effect?
Does the past... So I think it's where I am. Sorry, the past.
Yeah. The pulse pattern, whether biphasic or whatsoever pattern, as in RF, they have different pulse pattern that affect. Does the same thing happen? I mean, in the development of DBS.
Oh yes, I believe that is true. But that would be a much better question for my neurologist. I think. I'm sorry, I wouldn't be in the best place to answer that one.
Thank you, Professor.
Thank you.
Well, thank you very much, Professor Olson and Professor Horisawa. It was a wonderful session and we learned a lot about this. I would like to inform our viewers that as of now we have around 710 people who have joined us on various streaming platforms live now. So we'll move on to the second session, and I would like to invite Professor Keshav Das for a short brief introduction and invite Professor Leah Al-Hilali for her lecture.
Thank you, Raja. Can you hear me?
Yes.
Can you hear me, Raja? Thank
yes.
you, Raja, for the invitation, and happy to be part of the ACNS education program. So the next talk that we are going to have is quite an important one for the neuroradiologists, neurosurgeons, and many other specialists, the neurologists. And that is on the anatomy, the imaging and pathology of brachial plexus. As you know, this anatomical structure is a complex one because it goes through various anatomical landmarks, and it is essential that the radiologist or the neuroradiologist or the surgeon identifies these landmarks and then look at the part of the brachial plexus which is diseased. So anatomy is important, and there are various methods, imaging methods, which have been used. People have used ultrasound, CT myelography, MRI, and various newer techniques of MR imaging have come up, newer sequences have come up to visualize the brachial plexus. So I'm sure that today's speaker will be discussing about this complex anatomy and how you can get three-dimensional information about the various structures and their relations with the muscles and the various anatomical landmarks so that you can identify the various parts. The next would be about the pathology. There are traumatic and non-traumatic causes, and I'm sure that we will be hearing about the various traumatic and non-traumatic causes, pre-ganglionic, post-ganglionic, how to identify them, the importance of history taking. All these points are important, and I am really looking forward for this talk from Leah Al-Hilali from US. I think it's morning time. It should be there, isn't it? So good morning to our speaker, and to all of you, good morning and good evening or good afternoon. Let us have this session on brachial plexus. Thank you.
Thank you very much. Okay, so thank you very much for that kind introduction. Okay, everybody, raise your hand if you're confused by the brachial plexus. I could never actually seem to remember it or understand it, and I'm a neuroradiologist. And anytime I would ask a question, people would just throw a mnemonic at me, but they would never really explain it to me. So I made this talk to really delve into brachial plexus anatomy, imaging, and pathology. Okay, so we'll start with anatomy. So everyone has a mnemonic to remember brachial plexus anatomy. I'm a radiologist, so I remember the one about rad techs. We always say rad techs drink cold beer. But as I said, throwing a mnemonic to simply remember the names and their order isn't enough. It's really actually just the starting point. The point is that you really want to be able to understand it. So let's go through the mnemonic and really try to understand the anatomy. So from the mnemonic, we start with R for rad techs, and that's the roots, the cervical nerve roots. Now, I remember which roots make up the brachial plexus by remembering that it supplies your hand. And you have 5 fingers on your hand. So we start with C5 and we take 5 nerve roots. So that would be C5 to T1. So start at C5 and take 5 roots. Next in the mnemonic is trunks. Because trunks start with T, I can remember how they are named. T means top to bottom. So I can remember that the trunks are named from top to bottom, superior, middle, and inferior. But how to remember which nerve roots combine to give you which trunks? The pairing off of the nerve roots into trunks is kind of like the pairing off of a dance when there's an odd number. I'm from Texas, so we do a little bit of square dancing there. Whenever there's a dance, everyone immediately turns to the person next to them, and the person in the middle is left out. So for the nerve roots, C7 is the middle and is left out when the dance starts and has to go it alone as the middle trunk. Next in the mnemonic are the divisions. Divisions do what their name implies. They divide. So they divide the trunk. So each trunk is split or divided into an anterior and a posterior division. So divisions actually will look like scissors coming off of the trunk because they're splitting. So this helps you to remember that they are dividing or splitting and that these are the divisions. Now, this is not just an anatomic finding. This division results in a fundamental change in the nerves. The anterior divisions will supply flexors and the posterior divisions will supply the extensors. And this is an incredibly important dividing line in the brachial plexus. Like rabid soccer fans, right? I'm talking to a lot of people, I think, who watch soccer, not just like it is in the US. Once they have chosen a team, they will never mix with fans of the other team, right? So once they have chosen either to be on the anterior divisions in the flexors or the posterior division in the extensors, they will never mix with a flexor or an extensor. So after the split of divisions, the nerves will then come back together as cords. It's kind of like doing jumping jacks. They start at 3, open up to 6, and then close back up again. So I remember that they come back together to become cords because cords and combined both start with C. So together, 3 trunks, split apart, 6 divisions, combine for cords back to 3. So it's kind of like what happens when you go to a toll road. The road widens to let more cars get into the toll booth. And then once they have paid the toll, the road narrows again. And this is exactly what happens with the divisions. The road of the trunk opens up and then closes back up again for the cords. But in the case of the brachial plexus, instead of paying a toll, they are organizing into flexor and extensor groups and coming back again. But it's actually more like going through a wormhole than a toll booth. When you go through a wormhole, from what I've read on the internet, you are fundamentally changed when you come out the other side. So once the cords emerge from the division, once there's this combination come back together, they're either a flexor or extensor cord. They're either team flexor or team extensor, and they can never go back. These two will never mix again after the division. So when they form the chords, the anterior division, which is team flexor, will only combine with other anterior divisions. And they will only innervate flexors. So similarly, the posterior divisions or team extensor will only combine with other posterior divisions. So this anterior posterior flexor extensor split is now permanent after they recombine to form the chords. The divisions combine to form two anterior chords and one posterior chord. And you might say, well, why two anterior and one posterior? Why this inequality? Well, I remember this because the fundamental purpose of the arm is to flex, right? You pick up things, unlike the fundamental purpose of the legs, which is to extend or stand up. So because it's more important for the arm to flex, we're going to have two chords to the flexors and only one to the extenders. So remember, all posterior divisions will go into the one posterior chord, because remember, posterior and anterior divisions don't mix. And since there's only one posterior chord, all the posterior divisions will go into it. So how do you remember which anterior divisions will go into which anterior chord? Because there's two anterior chords. So remember, the divisions come from the superior, middle, and inferior trunk. The way I remember which ones will combine for the anterior chords is that I think of the superior and middle as kind of class, right? Superior or even middle class people, right? The high class people will not mix with inferior things. So the superior and middle trunks, the divisions from them will combine to form one chord, and the inferior division, the one that is from the inferior trunk, will be left alone. So the chords are actually named based on their relationship to the axillary artery. The posterior chord, which is our extensor chord, is posterior to it. The chord made of the superior and middle divisions is actually lateral. And then the middle division that's coming from the inferior chord is going to be medial. So, unless you have the axillary artery in front of you, this is actually kind of hard to remember. So I remember that the flexor chord is made up that poor inferior division. So remember, that was the one that had to go it alone because the high class people wouldn't go with that. So I remember that the inferior chord is made of the inferior class. And so it's given the worst seat right by the armpit. And the armpit is medial. So the medial chord is made from the inferior division. So now the final division is into branches. So remember, the posterior chord will only supply extensors and is the only extensor chord. So when it branches, it needs to innervate the extensors all along the arm. It is the only extensor chord. So it needs to supply the elbow, the forearm, and the hand. So it gives off the axillary nerve for the extensors on the upper arm and the radial nerve as the extensors for the hand. Now let's talk about the branches of the flexor chords. As expected from their names, the medial chord will give off branches for the flexors and sensation to the medial forearm and hand. And remember, in anatomic position, the pinky side is medial, so it's the ulnar nerve. And then the lateral chord will give off the motor and sensation to the lateral forearm, which is the musculocutaneous nerve. Now, usually the superior and middle class look down on inferiors, right? That's why they wouldn't combine with them. And that's why the inferior division had to travel alone as the medial chord. But eventually the rich have a, how should we say, an eye for the inferiors. And so it is with chords. Finally, the high-class lateral chord will mingle with the low-class armpit medial chord, making the median nerves. So now let's move beyond the mnemonics. Remember, the brachial plexus splits and recombines like jumping jacks in a very palindromic 5-3-6-3-5 pattern. The names tell you if they are splitting or combining. So I think about trunks are together, so that's when the roots will combine. Then the divisions will divide or split the trunks. And then the chords combine the divisions. and the branches break apart the cord. So trunk together, now that's going to be 3. Division divide, now that's going to be 6. Cord combined, that's going to be 3. And then branch break, it goes finally back to the 5, our original 5 nerve roots. So to remember the anatomy of the brachial plexus, you'll only need to remember one fact at each stage. When you form the trunks, remember C7 is left out. When you do the divisions, remember that the anterior flexors will never mix with the posterior extensors. And when you do the cords, remember that the superior and middle class don't mix with the inferior. So the inferior division goes alone. And then remember, for the branches, each cord will give a branch through the region its name to describe, either posterior, medial, or lateral. And then finally, we'll have a combination where the rich give into the inferiors to form the median nerve. Okay, let's talk about some imaging. So the brachial plexus is how the cervical nerves reach the arm. In the coronal plane, it looks kind of like a slide, guiding the nerves downward. Because the nerves are traveling laterally, the sagittal MRI plane is actually the best plane of choice to look at the nerves because it it cuts the nerves in cross section, and you can actually see down the barrel of the nerves. But the brachial plexus is more than a slide. It's really more of a complex highway with nerves joining and dividing, like highway off ramps and on ramps. So at the most medial sagittal cut, right after the neural foramina shows us the roots. Remember our mnemonic, rad, text, drink cold beer. The first part of the brachial plexus is the root. Now into sagittal plane on imaging, the roots look like the rungs of a ladder. They're all in a little line going down at this kind of slight angle. Now this makes sense because we are climbing up the ladder before we slide down the slide to go down the arm in the brachial plexus. So the anatomic landmark for the first rib, or for the roots, is the first rib head. And I remember this because the roots are the closest part of the brachial plexus to the CNS or the head. So they are by the rib head. So the roots together with the rib head make the ladder look more like actually a folding ladder. The rib kind of looks like the part that's supporting the folding ladder. So here are the roots on the sagittal MRI. You can see that the ladder rungs of the roots are supported like a little folding ladder by this first rib head. Next are the trunks. Trunks on the sagittal MRI are easy. They are arranged like, well, a tree trunk. So they are right behind the subclavian artery, which looks like a little shrub in front of our tree. So here's the tree of the trunks, and right in front of it, a little shrub that's the subclavian artery. So there are two real anatomic landmarks for the trunks. The trunks are at the posterior first rib head and in between the scalene muscles. So the rib and the scalene muscles look like kind of like an A-frame house, right? So here's the scalene muscles making an A-frame house. And then this is the bottom of the house. So the rib and the scalenes make this kind of A-frame house that you kind of see often in cabins in the woods. So this kind of makes sense for our trunk. We have an A-frame house in the woods, so there's trees and shrubs in front of it. So here are the trunks on the sagittal MRI. The trunks look like, well, a tree trunk. And the scalene muscles make up the A-frame house in the background, and here's our little shrub in front of our trunk. Next are the divisions. I remember what the divisions look like on sagittal images by remembering that the divisions are divine or dressy. They both start with D. So they kind of look like a fancy updo hair on top of the subclavian artery. The anatomic landmark for the divisions is the clavicles. The divisions sit actually behind the clavicles. I remember this because, Victorian ladies who would have these fancy hair updos would hide their face behind a fan. So similarly, the divisions, the fancy hairdo, hide behind the clavicles. So here are the divisions on a sagittal MRI. They are clumped together like a fancy hairdo above the head of the subclavian. And the clavicle is in front of them, allowing them to keep their little Victorian modesty from the prying eyes of men. Next are the cords. The subclavian artery and the cords are organized so they look like a paw print. And I remember this because both cord and cat start with C. So cords have a cat paw print. The anatomic landmark for the cords is the coracoid process. So cords are actually underneath the coracoid. And I remember this because cats who make the paw prints for the cords are always hiding under something, like hiding under a couch. So the cords, the cat paw print, hide under the coracoid. And I remember it's the coracoid because the cats hide when they're cornered. So coracoid and cornered. Here are the cords on a sagittal MRI with the paw print hiding behind the coracoid process above it. Finally are the branches. I remember the sagittal plane, the subclavian artery together with the branches around it look like a fat beetle with 4 legs. And I remember this because branches and beetles or bug all start with the letter B. So here are the branches on a sagittal MRI, where the subclavian artery is the fat body of the beetle, and these 4 branches that we see around it are the beetle's arms. So I remember the anatomy with this old-fashioned fairy tale. There's a house in the woods, which that's our trunk, home to a divine by shy princess, that's our cord. That's our division. She had a cat that hid under things, and that's our cords, ate all the bugs, and that's our branches in the home, because no princess wants bugs. So remember, house and tree is trunk, the divine princess is our division, the cat is our cord, and the beetle is our branches. Okay, so let's talk about some pathology. When it comes to brachial plexus injuries, the most important distinction to make is whether it is a pre or post-ganglionic injury. Pre-ganglionic injuries are basically nerve root avulsions from the spinal cord and cannot be repaired, while most post-ganglionic injuries can be repaired. I think of this like repairing a house. So if there's a structural flaw at the beginning, when it's just being designed, before you've even built it, you won't even try to build it. You'll just scrap the design. And this is like a pre-ganglionic injury. Before it's ever even formed, then you can't really repair it. You might as well just start over. But if there's damage after you've already built the house, you will definitely try to salvage it. You put all this money into it, you're obviously going to try to fix the house. And this is post-ganglionic. You can repair it. Pre-ganglionic injuries often have an associated pseudomeningocele. This is because when you rip the nerve root out, you also rip the dura. And it's kind of like pulling the cork out of a champagne bottle. Just like you'll have champagne splashing everywhere, CSF will also leak, creating the pseudomeningocele collection. Another sign of a pre-ganglionic injury is that there is actually no identifiable nerve root. Because the nerve root has been ripped out and retracted, you will not see it in the thecal sac, and the nerve root sleeve will actually just be empty, kind of an empty shell of where the nerve root used to be. So for plexus injuries, I remember the plexus is how the nerve roots jump down to the arm, kind of like a bungee jumper. Too bad our Australian friend isn't here with us anymore. So I think of these nerves like a bungee jumper tied to the top while moving down to the bottom. So I think of the injuries that can happen to the brachial plexus the way I think about injuries that can happen to a bungee jumper. Whatever can happen to a bungee jumper on their way down from the top, that's the same things that can happen to the brachial plexus on their way down to the arm. So the first problem on the way down is not great. The bungee cord attachment can rip off and you're basically left free falling. This is like a pre-ganglionic injury. And just like what happens to the jumper, if your bungee cord attachment rips off, there's no salvage with this kind of injury. So remember, for pre-ganglionic injuries, you need to look to see if the nerve root is missing and look for the characteristic pseudomeningocele. This will be your sign that there's a pre-ganglionic injury. The next problem on the way down is getting hit by external objects flying through the air. This is like radiation therapy, something coming in from the outside to hit the brachial plexus. Radiation plexoscopy will often show a diffuse thickening or enhancement of the brachial plexus, but there won't be any identifiable mass. When the thickening occurs, it kind of depends on the cancer and where they're radiating. So head and neck cancer will affect higher because that's where they're radiating. Lung cancer and breast cancer will affect lower. The next problem on the way down is crashing into something in the vicinity. This is like trauma. The brachial plexus can crash into the clavicle in front of it, kind of like crashing into the rocks below for the bungee jumper. It can also be stretched as well. There are three main things to look for with a traumatic plexus injury in order to identify. One, you will see edema. This usually indicates injury. Two, you can see thickening. Now, thickening can hide a neuroma and continuity, so it needs to be followed up. Once the edema and the initial swelling has gone down, then you may actually see a discontinuity. And finally, you may even see in the early period discontinuity where the nerve is disrupted. Now, if the disruption is post-ganglionic, this can possibly be repaired with microsurgery. So the Nagano injury zones show us that while we knew we could never repair pre-ganglionic injuries, if the post-ganglionic injury is not too far past the foramen, they are also just technically too difficult to repair. So really the only ones that you could truly repair with microsurgery are after the foramen. So remember, if it's not out of the foramen, it's foregone. So foramen, foregone. So pre-ganglionic and injuries that are post-ganglionic in close proximity to the foramen cannot be repaired. So finally, the jumper can get eaten by something. And this I consider to be involvement by tumor. It can be an intrinsic tumor to the brachial plexus, like a schwannoma, or metastases from something like breast. But most commonly, it's actually a direct extension from a Pancoast lung tumor. Now, a tumor can usually be differentiated by radiation changes by seeing an actual focal mass. Because Pancoast lung tumors come from below, they usually affect the lower cervical nerve roots, basically C8 and T1. So now you can remember the brachial plexus pathologies by remembering all the unfortunate things that can happen to a bungee jumper on the way down. So remember, cord rips off, pre-ganglionic avulsion. Getting hit by something on the way down, radiation therapy. Hitting something on the way down, trauma. And finally, getting eaten by something from below, that's tumor. So thank you so much. I really appreciate the invitation to come talk to you guys about the brachial plexus. If you're interested in learning more, you can follow me on Instagram and Twitter. I'm at Teach Play Grab, because when I say Teach Play Grab, I say that there's nothing more important in life than learning, living, and eating. Thanks so much.
Thank you, Dr. Ali Haliali. That was really an interesting way of presenting brachial plexus anatomy and pathology and imaging. Perhaps I have, as a neuroradiologist, heard several lectures on brachial plexus. This is the first time I'm hearing the artist way of how an artist puts the brachial plexus anatomy and makes it so simple by means of mnemonics and pictures. So it's really a learning experience for me as well, because this is also a way you can teach in a way that people can understand in a much better way. Thanks for that wonderful presentation. I just wanted to ask you one question. So do you at any time do ultrasound imaging, number one, and second for brachial plexus, and secondly, how commonly do you use the newer MR sequences like diffusion imaging and all for picking up pathologies?
So that's an excellent question. So ultrasound, I have read so much about how excellent it can be at imaging the brachial plexus. I'm in the US, so there is a strong incentive from a monetary standpoint to use the more advanced imaging. So we tend not to use ultrasound here in the US. We do use MR, it's a higher fee for service. So it's really used in terms of ultrasound in places that just don't have access to MRI. So most major centers just tend to go straight to MRI without using ultrasound. In terms of the imaging, we do use a lot of the advanced sequences. So the MR neurography is basically part of every basic MR protocol where we do a T2 fat saturation and black blood essentially sequence to null both the fat and the vessels in this region and do 3D imaging so that we can do multiplanar reconstruction. We also started using, in terms of doing imaging of nerves, the PSIF sequence, which is a very high resolution MR neurography sequence that we began using at the skull base. Another sequence that we're kind of trying to get into our protocols is the cranie sequence. We're right now looking at it with our MR researchers to make sure that the image quality is at the point where we want to use it clinically. We're still kind of doing it on volunteers. We tend not to use diffusion sequences that much simply because, especially in the brachial plexus, it doesn't give us quite the resolution that we would like to see that we get on the MR neurography images.
Yeah, so because there is this sequence DBS, which I think some people had started using for MR neurography to look at the pathologies. Another question I had was about CT myelography. CT myelography for traumatic injuries. Do you, for preganglionic lesions and all, how frequently do you use CT myelography to see the avulsion? And there are extremely good images which show how you can see by CT myelography the nerve being avulsed from the cord. So do you do it regularly or do you just depend on MR itself?
We tend to use MR. The MR, spatial resolution has significantly improved from even when I was, a trainee, that we can pretty much diagnose the preganglionic injury on MRI. If there is a question that we don't see an injury and they suspect that it's a preganglionic injury, then we will do CT myelography. And basically we kind of do it for confirmation usually. And yes, you definitely see it better on CT myelography. The spatial resolution just can't compete with MRI. But since it's not really going to be treated clinically, it doesn't really, impact that much to be able to, see it better. So if we can make the diagnosis on MRI, we tend to avoid the CT myelography.
Yeah, thank you. Thank you. Raja, you have questions or anybody else having questions, please?
We'll take questions, of course. Lou, any questions from your side?
It's quite interesting, Professor. Thank you for making a brachial plexus made easy program for today. My question, Professor, do you have any mnemonic related to symptomatology and also pathological MRI? Because it's very nice that you illustrate the MRI at different cut and the structure illustrated in your diagram. And do we have such imaging for pathological changes? For example, the cat become a different, the toe of the cat lack of one or two or whichever road that we are looking at, or do you going towards that in the near future, Professor?
Yeah, so in terms of the clinical stuff, I don't see patients, so I'm not so familiar with any sort of mnemonic for the diagnosis in terms of either the clinical presentation or the pathology. So basically, I kind of wanted to clarify, basically expound upon the mnemonic that we all remember the order. And then, I kind of remember the story, house in the woods, princess living in the house with her cat that ate the bug. And that kind of tells me where I should be along the line of the brachial plexus. And that kind of helps me to remember what I should be looking for on that sagittal plane.
Thank you, Professor.
Yes, Ben, any questions from you?
Yeah, thank you, Professor. Personally, I don't have any question, but I really appreciate and enjoy your lectures, and your cartoons is very nice. very artistic, and I really like the way you present the anatomy. And when I trying to learn the vertical plexus anatomy, those nerve, those branches, it takes me 1,000 times to try to remember it to get into my head. And I hope I get your lectures much earlier before today.
Thank you. Yeah, I have to tell you that every time when I was even making this lecture, like you go to these images for the anatomy of the brachial plexus, and it's like all these cords intersecting here, tons of lines coming off everywhere. And it's just like, it's overwhelming, and you're just like, whoa, I can't do this. So I just wanted to kind of break it down to make it more understandable for people. Because I think like looking at those diagrams, it's too much information and all at once. So.
Yes. And the anatomy is very important for neurosurgeons and all the regions, including the brachial plexus. And thank you for your lectures. Wonderful.
Thank you. We'll take the final comments from our Honorable Chair, Professor Keshav Das, before we wind it up.
Yeah. So thank you very much, Lee, for that wonderful talk. In fact, we really enjoyed your talk, and it's not only the talk. In fact, I learned a new method of learning, teaching students by means of pictures and various mnemonics. And this is something I'm sure as teachers, many of us who are here as teachers would love to start doing it in a regular practice, so that our students also get it very easily. The anatomy of brachial plexus, as I told in my introduction, it is a difficult topic, and you have made it very simple. Thank you very much.
Well, thank you very much. Now we know why Dr. Leah won the Teacher of the Year 5 times consecutively in a row.
That's great.
At the Barrow Neurological Institute. Thank you very much, Dr. Leah.
You can see the reason why.
Thank you, Professor Keshav Das and Professor Leah Al-Hilali, for this wonderful lecture. So I'll wind this up officially on behalf of the Education Committee of the ACNS and the President, Professor Yuko Kato. I would like to thank both speakers of today, Professor Sarah Olson and Professor Leah Al-Hilali, as well as the chairs, Professor Shiro Horisawa and Professor Keshav Das, for their time and support for the ACNS webinars. I would like to express my sincere gratitude to Professor Shubin for broadcasting this webinar on the WeChat channel, and as of now we have around 710 people who have joined us live. A special thanks to my co-host Liu Boon Sen and my dear friend Ben for joining me today. So until we meet again on the 5th of November, it is bye-bye from all of us. Thank you very much for joining.